There we go. All right, and it's in speaker view, so it will only, it's not recording everybody, or it won't. So thank you so much for being here tonight, everyone, for our Rise Up workshop tonight. As always, if you guys can keep your cameras on so that we can see your beautiful faces, yourselves muted so that background noises aren't distracting for the speaker. And if you have any questions, I'm sure that he would be more than happy to answer them. I don't know, John, do you want them to ask while they have it or at the end?
While we're doing it,
Okay. Perfect. So if you guys just raise your hand or unmute and ask, whatever you feel comfortable, you can also drop it in the chat box and I can ask for you if you feel more comfortable doing it that way. But I don't want to hold up our speaker any longer. Thank you so much. And please pronounce your last name for me again.
Cousino.
Cousino.
Cousin with no on it. Greetings, guys and gals. It's nice to meet you all today, and hopefully we can learn a few things here. Just a quick who I is. Another person coming in. Some Girl Scout cookies. Actually, some Girl Scout cookies would actually sound pretty good right now. Actually, with the Boy Scouts are selling moon pies in this area now, so I guess I got to buy moon pies. I work with both groups. That's how I sort of know what everybody's doing. Just a short bio on myself. I'm a professor here at Chattanooga State Community College. Been out here for about 30 years. Really love it. So I thought I was going to stay here for 5. But I enjoy teaching. I enjoy the students. I'm a professor of allied health, and with a specialty, I am a clinical coordinator for the respiratory care program here. So if anybody wants to become a future phlegm sucker, look me up. We always need more phlegm suckers. And right now, my students really are right in the heart of all the COVID stuff. So that's a big area where my students are needed at. This crowd looks a little younger than I was initially expecting, so I can't make too big of a job push here to come out to Chattanooga State, but it is an excellent institution to come out here and get your education, especially if you're in the allied health areas or actually engineering in our technical fields. If you want a job, they're out there, and we can help you get that part of it. So that's my official plug for the institution. So I've been longer than a respiratory therapist. I've been a paramedic. I've been a paramedic now. This is my about 45th year as a licensed paramedic. Started off in the state of Tennessee. Been active up here. I've got a critical care certification. That's enough of the junk stuff. What we're going to present today, unfortunately, is too relevant. I really hate the idea that this is probably one of the more relevant talks that I give to a lot of youth groups, scout groups, school groups here. We put on programs here at Chattanooga State for this. If you guys have been watching any part of the news, you've seen lately, we have a very active knife and gun club here in Chattanooga itself. And by an active knife and gun club, I mean people are getting shot in places you never would have thought of. It's saying in schools, parties, looks like Walmarts are not safe. There's no place, unfortunately, anymore that's safe from somebody that's a nut. It wants to do harm to people. And that's sad and scary. But let's see now, it's probably about 7 or 8 years ago. Some of you folks may remember the Sandy Hook incident where the person, the nut, because I'm in a mixed group, I got to use the right word. I have much other words I would have used for those individuals, but I try to stay in polite company. Brought the national attention really to mass shootings and what goes on in a mass shooting. The presentation I'm going to do is a national program that came out of that. It's a couple different groups. The National College of Surgeons put it partly together. The Department of Defense put part of this together. The Committee on Trauma and Combat Care put this together. And that's some of the agencies I'm coming from and here and doing this. The videos I've got here, I picked these out because I'm one of these people who like real things. Normally I do this presentation in person, and I'd bring fake arms out and fake legs and tourniquets, and we'd be able to slap them on each other and practice doing all this stuff with the fake arms and legs. But unfortunately, because of COVID right now, maybe later on we can get together again and I'll bring out all my fake arms and legs, and you guys can have fun sticking things in the holes and stopping all the blood and coming out, all the other fun things like that the kids like doing. Maybe something we ought to do around Halloween. I got to be good. Yeah, your job, Sandy, is I get too carried away. Please mute me. So starting this off here. Basic part, if you hadn't memorized anything from this presentation, is the red stuff stays on the inside. That's our goal, is to keep the red stuff on the inside. Red stuff should not be on the outside. Okay? And everybody, I hope, understands what I mean by red stuff, right? That the red corpuscle looking things, that blood type stuff that we're supposed to keep on the inside. And we're going to look at some ways that we as lay people, you guys especially, can maybe possibly save your own life, or more likely maybe save the life of one of your colleagues or friends if something happens where you may be the only person that's there to help them. Again, if any of the videos I show today are a bit too extreme, I will apologize partly in advance, partly since this program was actually videotaped from a trauma surgeon did this presentation. He went a little bit realistic because he had access to the real stuff. So you will see some bleeding arms, you will see some severed legs, you will see some real wounds, and actually see them really being cared for and done with. So if that's too much, please mute out for a few minutes and come on back, and I won't hold that against you. And again, it's something that the average person, hopefully you never have to see. And my prayer is that you never have to use this. I teach CPR and a bunch of other things like that. And I tell people the only reason I teach CPR because one day I might need it. All right, so let me give you a scenario, guys. Unfortunately, and I'll use my institution here because if there was an active shooter here in Chattanooga State, I'm in the Allied Health Building, the second floor. If we had an active shooting here, you got a couple choices. You can run, which is not a bad idea. If somebody's shooting, run away as fast as you can, as far as you can. Good idea, get out of the picture. Sometimes you might have to fight, and that might be the only choice. Or you might have to hide, which is also a good choice. So again, that's another course. But let's say I've got an active shooting here. I hear gunfire outside my office. I lock my door. I hunker down here for a little bit. And after the gunfire stops, because who I am, I'm going to go out there anyway. The first officer who gets here, this is sometimes people don't understand this. His first job is to protect himself. His first job, he will step over me if I'm a victim. His primary responsibility is to neutralize the threat. That means he's got to find the bad guy. And that's the first officers coming into the scene. That's their job. They will literally step over patients, step on patients, whatever they got to do. Their focus is to neutralize the threat. If I'm sitting in with my ambulance, they've got me stationed a mile away. They will not let me come in treating people until the scene is safe. So if you got shot there and you're bleeding, who's going to help you there? Well, the officer's job is to take care of the threat. Who's going to take care of you? And that's really the purpose of this course is we're going to help you guys in yourselves and also into some of your fellow friends to be able to, if I'm shot, what can I do to stop the bleeding? What can I do to keep the red stuff on the inside? And that's it. And shootings can happen. An accident at home, you're playing around with your little brother or big brother, and you push him, and all of a sudden they go through the plate glass window, and he's got a big cut on his arm or leg. Or you're out with your parents, maybe cutting some wood in the backyard, or using a chainsaw or power saw, and something happens. Or you're in an auto accident and somebody's got a major laceration. All the steps we're going to look at here today all go for that. So let's see if we can get into this. In school, guys, do you have, a lot of your schools don't have AEDs, right? Automatic electrical defibrillators, big boxes. Does any of your schools have stop the bleed kits in your schools? There are red boxes usually sitting right beside the AEDs that stop the bleed. Any of you guys seen those? Oh, I got one yes. All right. All right, good. Hopefully somebody in your building knows how to use them, and I guarantee after today, you will know how to use them if they're needed. And that's another national thing they're pushing out, is putting these stop the bleed kits right next to the AEDs. So if there ever is an incident, you have some supplies to work with. And we'll talk about how to use those nice commercial supplies. And we'll also talk about how to improvise some things that we have to, again, to try to keep the red stuff on the inside. So let me start this and see if this works. He'll introduce himself, but he's a trauma surgeon, fairly well known, very good one. And the presentation he's making here is, I believe, to other medical students or other physicians. So you can understand a little of the level this is at. And again, raise your hands, we'll stop it if you got some questions. And again, if it gets a little too gross, or a little too much, just turn away for a little bit. There's not much like that, but hey, I'm a male. I like a little bit of blood and gut on occasion. As long as it's simulated, not mine. All right, so let's see, I want to share screen, and I want to share, I think that's the screen I want to share. You guys seeing a screen that says stop the bleed? Very good. Let me see if it'll play now. Can you hear me? Can you hear it?
Sort of through the college, the main governing body of trauma care.
You can make it a little louder.
I will see if I can.
Also has education and teaching programs, and this is one of their main teaching initiatives. There's several of us on the faculty that are heavily involved in the committee on trauma. Dr. Doucette, myself, Dr. Godat are all on the committee. And so
I think I got about as loud as I think I can get it.
Get this course taught to as many people as possible. So this course, the genesis of this course really came out of some, major disaster events in this country, especially Sandy Hook, the Orlando shootings, places like that, where the issue is that patients are dying from bleeding from extremity trauma. And the feeling is no one should die from bleeding from extremity trauma, because that's something that we can all stop. Now, it's made complicated in these mass casualty situations when first responders can't get there in a timely fashion because the scene may not be safe. There may be so many casualties that they overwhelm the number of paramedics and EMTs that arrive. And so if we can, teach people how to provide basic primary care to these people, basic hemorrhage control, that we can ultimately save lives. And so the idea is not just related to disasters. I think we've all seen this in the trauma bay. There's, workplace accidents with severe hemorrhage. We've seen school children who have been, cut on the playground with actual arterial bleeding that was not, controlled well enough and led to transfusions and things like this. So we want to teach these skills to as many people as possible, and then also provide the supplies that they need to perform adequate bleeding control. So again, this was started by something called the Hartford Consensus. This was a group of people that were brought together after Sandy Hook to really ask the question, how can we add, national resiliency to respond to these sorts of incidents and to provide, life-saving interventions in these sort of terrible circumstances. This has been supported again by the American College of Surgeons, the Committee of Tactical Combat Care, which is the military organization, the National Association of EMTs. It was supported by Homeland Security, supported by the White House under the Obama administration. So this has had wide acceptance both within the healthcare community and also within the government itself. All right, so again, the focus of this program is how to provide an immediate response to bleeding patients. We're going to teach you how to recognize life-threatening bleeding, which I think this group doesn't need a lot of education on that, but we'll not only recognize what is significant life-threatening bleeding, but also how to control that bleeding based on location of bleed and based on the supplies that you have available to you at that time. As it says here, the help given by an immediate responder can make the difference between life and death. You can play an important role before the paramedics get there in these situations. And with the right training, we can all help save a life if we need to, if we ever find ourselves in that situation. Some of the images are graphic. I think you guys will be okay. Why do I need this training? Well, you need this training because injuries and bleeding can happen anywhere. They can happen through work-related injuries, through injuries at home, motor vehicle crashes, and then obviously they can happen in mass shootings and mass casualty events, which unfortunately we see can happen anywhere, airports, workplaces. So we need to be ready for such events. So we're going to go through really the basics of the Stop the Bleed course. This is sort of the overview of how you need to think about this when you come across a situation where there may be a patient with life-threatening bleeding. First and foremost, ensure your own safety. You can't help somebody if you yourself get injured. So you need to make sure that you're safe and it's safe for you to approach the patient and provide care. And then the ABCs of bleeding. A, alert. So either yourself or ask someone else to call 911, because what you're doing is a temporizing measure until paramedics get there and patients ultimately get to us at the trauma center. You want to B, look for bleeding, find the bleeding injury or injuries, determine which ones have potentially life-threatening bleeding. And then C, compress them, apply pressure to stop the bleeding. And that can be done either by direct pressure, it can be done by using tourniquets, or it can be done by using a hemostatic dressing. And we're going to go through each of these options through the course. And then at the end, we're actually going to have skill stations where you can demonstrate these skills. Once you pass the course, you will get a beautiful certificate, which I will provide you later. We'll also be providing everybody with their own bleeding control kit for you to take home or put in your car. This has all the gear that you need.
Sorry, group, I will not be providing those.
Part of your take-home gifts from today. Okay, so again, going through the basics of the ABCs of providing bleeding control. The first, and very importantly, is safety. So before you offer any help, you have to remain safe. Of course, if you're injured, you will not be able to help the victim. Only, initiate care or approach the patient if the scene is safe, if there's an active shooter event that has been, obviously taken care of, that the scene is safe. If there's no other risk from any, debris or other falling, things from a mass from a disaster event. And then if anytime you feel threatened, so you approach the patient, you're trying to help them. If the scene changes, again, if it's not safe, you got to get out of there. You can't be hurt as well as your victim. The other important point is to protect yourself from bloodborne infections. If available, wear gloves. There's gloves in these kits here. The goal is for us to start getting these kits in public places, much like you would see AED boxes in public places and airports. UC San Diego Health has gotten some money together to start putting some of these boxes in public places within our hospital, which will have boxes that can contain 10 or 12 of these kits so that you can deal with multiple injuries. We're working with the airport to get them at the airport, Petco Park, other large places like that. So you may start actually seeing these bleeding control kits so that these supplies are available to you if you're out in public somewhere. All right, A for alert. So we're going to talk about the ABCs of bleeding control. A for alert, so you need to get help. So call 911 or tell somebody to call 911 for you. You need to make sure that the emergency medical responders are aware of the situation and are en route. Again, what you're doing is not definitive treatment. The treatment you're providing is temporizing until they arrive. All right, B for bleeding. So find where the victim is bleeding from. Sometimes you need to open or remove their clothes to really identify the wound or wounds to see what's bleeding and how much it's bleeding. And then you want to look for and identify potentially life-threatening bleeding. And I think, we all sort of know that when we see it, but some of the basics: blood that's spurting out of the wound, blood that won't stop coming out of the wound, blood that pools on the ground or soaks clothing, bandages that are soaked. Obviously, if you have a muscle amputation, that's bleeding. And then bleeding in a patient who's confused or unconscious. Why is that a concern? So let's say you see the patient, they don't seem to be, you don't see a lot of, sort of necessarily arterial hemorrhage or blood squirting out, but they're altered. But you have to worry that they're in shock, right? So change in mental status is a sign of shock and a sign of significant blood loss. So while they may not be hemorrhaging significantly right now, maybe they bled on the way, to getting to where they were, and then they've sustained significant blood loss. So you need to be aware of that. So there you go. There's blood spurting out of a wound. So that would obviously be concerning for potentially life-threatening bleeding, something you'd want to treat, but maybe a little less clear is this manual extremity here on the side. You don't see necessarily.
That's actually a simulation, but it's good.
There can be pretty significant blood loss from that, from the muscle bones and potentially even the blood vessels.
That's actually a chicken leg.
On the sheet underneath, and again suggests that there may be significant blood loss. That's probably the worst picture you can see. So if you made it through that, congratulations. All right, so now back to the ABCs, we're gonna B for bleeding. So we're gonna classify bleeding by its location of bleed, because based on where the bleeding occurs will dictate a little bit what kind of therapies you can provide as a first responder. So arm and leg wounds, these are the most frequent causes of preventable death from injury. These are the types of bleeding that we should be able to stop and that we should be able to prevent people from bleeding from at the scene. That's really the goal of the course, is extremity injury. These wounds, bleeding from these wounds can be controlled either by direct pressure, if you know how to do it correctly, or better yet, tourniquets if you have access to them. And again, that's why we think it's important to get these bleeding control kits, not only in your car, but also in public places so that you have tourniquets available if you need them. So we'll talk a little bit about how to approach that. The other area of injury is areas of junctional hemorrhage. So areas of junctional hemorrhage are in the neck, the axilla, the groin. So these areas that sort of go from the torso onto the extremities. These are important because you can't use a tourniquet here. You obviously can't put a tourniquet around the neck. You can't get a tourniquet high enough above the axilla to actually get it to compress, and the same is true in the groin. So you need to, your approach here is going to be a little bit different, and where you're going to have to either rely on direct pressure or wound packing or hemostatic gauze. And then the final area of injury is the torso. These are not injuries that you're going to be able to care for on the scene with direct pressure or any sort of bleeding control intervention. These are patients that need to come to the trauma center. They've got some sort of internal source of hemorrhage that we're going to need to fix operatively. And so these people need to be recognized, and obviously when the EMS teams arrive, potentially direct them to those patients accordingly. These are not people that you're going to be able to apply to provide hemorrhage control yourself at the scene. All right, so we'll talk a little bit about an algorithm here for bleeding control. So as we talked about, number one, ensure safety. Number two, look for life-threatening bleeding. If you identify potentially life-threatening bleeding, then you have to ask your question, well, what supplies do I have, right? Because you're going to be limited potentially by the sorts of supplies that you can use to provide care. So you ask, is the trauma first aid kit available? Do you have one of these or something like it? If the answer is no, what are you going to do? Nothing? Yeah, find something else, right? So use a clean cloth or gauze and apply steady pressure to the wound. And I think we all have seen that and know how to do that, but that's a skill that we're going to practice here in a little bit. So the important part of direct pressure here, so you're going to use your hand or fingers, and use two hands if at all possible. And you're going to want to do that in a fairly forceful manner, so almost like CPR with your shoulders right above your hands. This is effective most of the time for external bleeding and can stop arterial bleeding if you do it correctly. It requires very firm, continuous pressure until the medical responders arrive. That means you apply pressure, you've done a great job, the bleeding stopped. Should we take a peek and see if it's still bleeding or not? No, we need to keep pressure on there, because if you take your hands off, you may lose bleeding control. You may not be able to get the bleeding control established as well as you did before. So once you have achieved hemorrhage control, you have won. Just keep doing what you're doing and wait for EMS to arrive. Sometimes you need to move the patient onto an.
I think I may have messed up there. I'll go back and fix that. Sorry about that. Any questions so far while I try to get back to what I was doing here a second ago? So who's most important that you take care of, guys and gals out there? Who's the person you worry about the most? You got to take care of yourself first. It may seem strange, but at the end of the day, you want to go home, and you got to take care of yourself first. And if you don't take care of yourself first, you can't help your friend. So again, take care of yourself first. Only go out and help someone if it's safe. If for some reason you don't think it's safe, get the bejeebies out of there. Going. If your spider senses are telling you this is not a good place to be, I would definitely say get out of there. I think I pull us pretty close we were before. Yeah, right about there.
Clean cloth or gauze and apply steady pressure to the wound. And I think we all just keep doing what you're doing and wait for
Yeah, I think.
EMS to arrive.
Do y'all see that now?
Sometimes you need to move the patient
Yeah,
onto
yeah.
an appropriate surface. You can imagine if they're, you know, on some sort of soft surface or raised up, you may need to get them down on the ground or onto a hard surface in order to apply appropriate pressure, and that's okay. And you know, this kind of pressure should hurt the patient to some degree, right? If you're holding firm pressure enough, it's uncomfortable. And that's okay because you're doing the most important thing, which is providing hemorrhage control. All right, so here's the picture. So as you all I'm sure do, as I do myself, I always wear a clean white shirt when I run out in public in case these sorts of things occur. So, you know, if you see a patient with hemorrhage, use any kind of clean cloth you can find. It might be a towel, it might be a blanket, it might be gauze, it might be, you know, some sort of clothing. But use that basically to cover the wound and then apply direct pressure over the wound. Remember that in these wounds, sometimes the bleeding is proximal a little bit to the open wound, and sometimes you may need to move your pressure up a little bit in order to stop the actual source of bleeding, which is at the top aspect of the wound. If the wound is large and deep, stuff the packing in there, stuff the cloth, whatever you have, stuff that inside before you hold pressure because it'll fill up some of that space and improve the manual pressure that you're holding. Apply continuous pressure. See nicely here, his arms are straight. He's using two hands. His shoulders are above his hands, and he's applying pretty steady, firm, direct pressure right onto the wound. Press down as hard as you can and then wait until medical responders arrive. All right, well, what if you have a trauma kit available? How does that change what you might be able to do? Well, in theory, you still have gauze, but you also have the ability to potentially have a tourniquet. So then you need to ask the question, where is the wound? Because tourniquets, again, can't be used everywhere. So if it's on the arm or the leg, you've got more options. If you have a tourniquet readily available, then you can use it. Who's put a tourniquet on before? Okay, a couple of you. Is it easy? Is it hard? Well, it's easy if you know how to do it, right? But it's also pretty easy to put them on incorrectly if you don't know how to do it. And that's an important part of this course is to show you the appropriate way to apply a tourniquet. So here's a tourniquet. This is a blue tourniquet, which maybe many of you haven't seen, which means it's a training tourniquet. Most tourniquets are black, and there's various different kinds, which we'll look at here in a minute. Don't use training tourniquets on patients because they've been used a lot and will sort of wear out and not work as well. The same is true with your bleeding control kits. I'd recommend not opening them up and playing with them or letting your kids play with the tourniquets, because the more you use them, the less they're going to work well when you actually potentially need them. The Velcro wears out, the tourniquet itself can stretch and not work as well. So try not to use them if you don't have to. So a tourniquet's a device that stops the flow of blood. If applied correctly, the tourniquet will stop blood flow into the extremity and will limit blood loss. And you can see a tourniquet nicely applied there above the wound. So tourniquet application, apply these immediately if life-threatening bleeding is seen from the extremity, from the arm or the leg. A tourniquet can be placed on top of clothing. However, it's not necessarily ideal. And you don't want to apply a tourniquet, over somebody's cell phone or keys or junk that they have in their pocket, because it's not going to work as well. So make sure that stuff's out of the way. If you have just clothing underneath, it's okay to apply the tourniquet, but make sure there's nothing else there that's going to interfere with the pressure. The pressure that you want to apply with this tourniquet is pretty significant. And if you don't get it really tight, what happens if you get this on almost tight enough, but not quite? What's going to happen? It might actually bleed more, right? Just like the little rubber band tourniquets you put on an IV, right? You get some venous occlusion, which can actually, in this case, make it bleed more because there's no venous drainage plus the arterial bleeding. So you've got a bit of a double whammy there. All right. You're going to put this on 2 or 3 inches above the wound, but don't put it over a joint. So it's okay to go higher. These don't belong on joints because, again, they're not going to apply appropriate pressure. So here's some different tourniquet types. The combat application tourniquet, which is the CAT tourniquet, which is the kind that we're going to use today and the kind that you're going to get in your kit. These are very common tourniquet that are carried by law enforcement providers here in San Diego and used in the military quite a bit. There's also the soft T tourniquet, which you may see, which is very similar. It just doesn't have any Velcro. And so it can be used, it's a little quieter. It can be used by special forces if they need to, because if you're trying to be stealth and quiet, it's probably not ideal to have that sound happening all the time. And then the emergency and military or EMT tourniquet, which is a sort of elastic-based tourniquet. They all work in the CAT tourniquet and the soft T work in a very similar fashion. We'll go through the specifics of how to put that on. Military's preferred tourniquet. It's easy to use and can be rapidly applied. So it's a pretty basic thing. It's got a Velcro strap, which you can slide the extremity in through here. It's got Velcro. These are designed to be put on yourself if you need to. Basically, you can apply the Velcro. The real key when you're putting this on patients is to get this Velcro down as tight as you can. Put a lot of force on and really put the Velcro on tight to make sure that you're starting from a good spot. You have this thing here, which is called a windlass rod, which will give you extra tightening. You can crank this down to really make it tight, but it's only going to do so much. So if you haven't put the Velcro on tightly enough, you're not going to be able to fix it by twisting this thing here. The windlass rod, once you twist it down until the bleeding stops, you can hook it into this little clip right here. You can put this little Velcro on the top, which you can write the time that you put the tourniquet on. Okay, so pretty simple. You can get these on very rapidly and in a fairly straightforward manner. So again, we're gonna go through it step by step again in pictures, and I'm gonna show you a video as well, just to make sure that we all understand. So the first is insert the wounded arm or leg through the CAT tourniquet. Step 2, pull the self-adhering band tightly, and really 2 hands pull it tight and get the Velcro down. Be sure to remove all the slack, because that's why your tourniquet will fail, because you didn't put it on tightly enough to begin with. Adhere the band around the extremity, and do not adhere the clip past the band, because you're going to need to twist the rod here in a second, and you need space to do that. Twist that windlass rod and keep cranking it until the bleeding has stopped. Once the bleeding stopped, you'll put that windlass rod into the clip. You can put the elastic band then to cover the rod and through that little clip before you cover it with that white piece of Velcro. And then again, it's helpful, especially if you're treating multiple people, to write the time on there. That will give information to the EMS team and to the hospital as to how long that's been on there. It does. Yeah. Funny you should ask. All right, here's a video.
This video will demonstrate the application of a combat application tourniquet, or CAT, to control an external hemorrhage in an upper extremity when direct pressure is unsuccessful. Place the wounded arm through the loop of the tourniquet. Position the tourniquet approximately 2 inches or 5 centimeters above the wound. Do not place the tourniquet directly over a joint. Pull the free end of the tourniquet as tightly as you can and fasten it back upon itself. Do not adhere the free end of the tourniquet past the windlass clip. Twist the windlass rod until the bleeding stops. If the free end of the tourniquet was pulled as tightly as possible in the previous step, this will usually take no more than 2 or 3 180-degree turns of the windlass rod. If it takes more than 3 turns of the windlass rod to stop the bleeding, the free end of the tourniquet was not pulled tightly enough. Lock the windlass rod in place into the windlass clip. Take the remaining free end of the tourniquet and thread it through the windlass clip and over the windlass rod. Grasp and pull the windlass clip strap over the windlass rod. Pull the strap tight and adhere it to the windlass clip. If the bleeding does not stop after the proper application of a single tourniquet, apply a second tourniquet directly above and adjacent to the initial tourniquet.
Okay, so that's an important point. Two tourniquets are okay. If you put the first tourniquet on and it hasn't worked, and you put it on correctly, put a second tourniquet on above it. There's nothing wrong with that. Your goal is to get the bleeding to stop in whichever way that you can. It's windlass. Yeah, windlass rod, WINDLASS, windlass rod. So we recommend that you use a real tourniquet, one of these or one of the other commercially made products. We sort of, we don't recommend using improvised. So the idea that you can put your belt on there and use that as a tourniquet is, as you'll see when you actually put these tourniquets on, you really have to tighten them extremely tight, plus have that rod to get enough pressure. It's pretty difficult to do that with an improvised tourniquet. And very frequently improvised tourniquets fail. And again, when tourniquets fail, they can actually make bleeding worse. So we need to try to use the right products. Second tourniquet's okay. Just put it above the previous tourniquet that you've placed. You can also put tourniquets on and hold direct pressure. Do whatever you have to do to stop the bleed. This is important. Everyone worries. Well, do I need to worry about putting a tourniquet on because there's a lot of concern that I put a tourniquet on that you're going to stop blood flow to the rest of the extremity, and that can be a bad thing. No amputations have been caused by a tourniquet when left in place for fewer than 2 hours. It's best to get the patient to the trauma center as soon as possible, obviously, to provide them definitive treatment and get the tourniquet removed as soon as safely possible. But putting a tourniquet on to stop life-threatening bleeding is the right thing to do. You shouldn't worry about any of those other consequences because this is a safe practice, and that's why we're teaching it. It's better to risk damage to the arm or leg than have a patient die, life over limb. And again, as I mentioned, the training tourniquets, the blue tourniquets, should not be used in a real scenario. Tourniquets really hurt. So I told you your patient may complain at you when you're holding direct pressure because it hurts. They might be screaming at you, I think, as some of us have seen in the trauma bay. These are extraordinarily uncomfortable. Again, that's okay. Let's put it in the context of why we're applying that tourniquet. Because they're having a lot of pain doesn't mean you put it on incorrectly. It does not mean that you should take the tourniquet off. And they can be treated with pain medicines when the paramedics arrive and ultimately taken to the trauma center and cared for there. The other common question is, well, if I put the tourniquet on, should I take it down every once in a while to let the rest of the extremity get a little blood flow? Don't do that. Terrible idea. Once you've obtained bleeding control, you've won. Don't do anything to mess that up. All right, common mistakes with tourniquet use. Not using a tourniquet or waiting too long to apply it when there's life-threatening bleeding. Not making the tourniquet tight enough. Not using a second tourniquet if you need to. There it is, periodically loosening the tourniquet to allow blood flow to the injured extremity. Not a good idea. And then removing a tourniquet. It's your job to put them on and to put them on correctly, hopefully, but it's not your job to take it off. That's what we'll do when they come into the trauma center. Okay. All right. Any questions about that? And again, we'll have practice stations at the end where you'll all get a chance to do this in a hands-on fashion and demonstrate that you know how to do it. Yes. Yes. Tourniquet practice later. All right. So what happens if you don't have a tourniquet available? What should you do then? So you can use hemostatic gauze or any sort of gauze or clean cloth and apply continuous direct pressure. The other scenario is if you have a wound in those junctional areas as well, they are not amenable to tourniquet placement. All right, so hemostatic dressing. So I think, we use these occasionally in the trauma bay, but not terribly frequently, but we do stock it. So this is quick clot or combat gauze. This is gauze impregnated with kaolin in most cases, which is a hemostatic agent, which can, use the benefits of the gauze for packing the wound and for pressure, but also to provide some hemostatic or some blood clotting ability. These are recommended as part of the Stop the Bleed course. They are not in your kits. and they will not be in all kits that you might see in the public. And the reason for that is, one, these is pretty expensive in comparison to the entire kit. And also these expire. So you can imagine if you're going to put these in public places, these have to be changed out every 3 years. That adds a little bit more of an issue as far as maintaining those kits. The rest of the stuff in here, as long as you keep it in its container, they don't expire, and you can keep it forever as long as you don't wear them out. But in the case that you do have hemostatic gauze, we recommend that you use it in these areas of the life-threatening bleeding, either in junctional areas or when you don't have a tourniquet. And there's a lot of names for these different products, but they all basically are the same thing. So again, we're back to wound packing. Open the clothing around the wound so that you can see the entirety of the wound. This is important now if we're actually going to pack this wound tightly. So you want to see the entirety of the wound. It's okay to remove excess pooled blood that might be sitting in the wound to try to get that out of there so that you can really pack this tightly. And then locate the source of the most active bleeding and direct your packing and your pressure to that area. So to pack the wound again, hemostatic dressings, if you have it, you can use a gauze roll, which you do have, or you have a fairly large piece of gauze in your kit, or again, that nice white shirt that you're wearing out to the mall in most cases, just in case. Stuff it right into the wound and apply direct pressure again, using 2 hands and using quite a bit of force. Here's a nice little diagram. We want that wound packed for the entirety of the wound. That means sometimes straight down, sometimes the wound goes proximally or distally. You want to pack the entire cavity. The more packing you can get into there, the better. Don't just, in this case, don't just lay the gauze on top, because you're not going to actually pack the wound itself or provide pressure into where the bleeding is coming from. Quickly apply and hold pressure directly on the packed wound until relieved by medical responders. If initial packing and direct pressure fails, you can add more gauze on top of it. You can hold pressure, try holding pressure in a little different spot. Keep packing the wound as much as you can and hold as much pressure as possible to try to stop the bleeding.
This video will demonstrate how to pack an open wound to control an external hemorrhage when direct pressure is unsuccessful. The packing and application of direct pressure is used to control external bleeding in wounds located in sites that are not amenable to tourniquet placement. Wounds may be packed with either a hemostatic agent impregnated gauze, such as combat gauze, or a plain gauze roll. To begin, open the patient's clothing at the wound site to expose the wound. Gently remove any pooled blood with plain gauze pads while trying to preserve any clots that have already formed in the wound. Locate the site and source of the most active bleeding. Pack the selected gauze product directly onto the bleeding point and tightly into the wound. Apply direct pressure onto the packed wound with your hand.
Any questions about wound packing? Yeah. Absolutely. Do all of the above. Yep, all of the above in order to try to get it to stop. Absolutely. All right, we will practice this at the end. All right, so blood exposure. So again, if you have access to gloves, obviously wear them. If you have exposure to blood, obviously wash it thoroughly once you're done with the incident, and let the medical responders know, and have yourself tested appropriately, and potentially the patient tested as well. All right, so summary, again, the ABCs of bleeding control. You're going to A, alert, call 911. B, find the bleeding injury and determine if it is potentially life-threatening bleeding. If it is, you're going to C, compress or provide bleeding control. You're going to think about where that bleeding is located, on an extremity. Is it a junctional injury? You're going to think about the supplies you have. Do you have a bleeding control kit? Do you have a tourniquet? And then based on those supplies, you're either going to hold direct pressure or apply a tourniquet or tourniquets to stop the bleeding. Again, the only thing more tragic than death is death that could have been prevented. So hopefully today way you are all more prepared to help somebody in one of these situations and to stop the bleed.
All righty, let's see if I can get my end quiet up here. All righty. Well, I hope that was interesting, I hope. Again, if we were, hopefully would, maybe sometime here in the near future, we can get together, and I've got all this play toys to play with, that we can get together and let you guys have some actual time of putting tourniquets on fake arms and stuffing gauze and stuff and bleeding holes and stuff. Anybody, any of the group have any questions or anything else they want to ask me, or anything I can help them with while we got me here for the next 5-10 minutes? Hopefully it wasn't too gross for some of you. But if, when I was 13, 14, you couldn't make it too gross. That just made it better.
I think it was very informative. It had a lot of great points.
Again, this is basically the same presentation I'll make in person, but he has some great videos, and I love the videos. I love the fact he was talking to other trauma surgeons, basically, or his residents. I think that shouldn't gross any of you guys out there. Hopefully, none of you guys again ever get involved in this, ever have any instance where you have to use this training. But again, as the news keeps playing every evening, going like it's more and more likely that sometime in your young careers you may come across some of this. Again, the idea, remember, getting out of this, what John says, the red belongs, keep the red on the inside. And that's the whole idea of this stuff, is to keep the red on the inside. Anybody want to unmute? Got any questions for me? No, that scared too many of you guys and never going to work a career as a paramedic or EMS or as a trauma surgeon? All right, well, good. I'm glad that hopefully got some stuff. Again, sometime in the future, you guys want to invite me when you have real meetings, we can do some of this stuff and also do some other presentations in most areas of EMS or first aid or anything else you guys can come across. I'd love to see we can either connect you with some good experts in that area, or I'll do it myself if I absolutely get desperate.
That sounds
I got a
great.
hand up. Yeah, please unmute yourself and say hi. I will destroy your name. Awama kid? Awesome kid. Okay, awesome kid. Oh, that was your name. Awesome kid. Hello, awesome kid.
I was wondering, is any of that stuff different for like small children or infants?
No, but you have less red stuff. Smaller the person is, the quicker they will bleed out. So again, if they've got a major cut, you put the direct pressure on it. If they need to use tourniquets, use tourniquets. Especially if you're thinking about your younger brother, your 3 or 4 year old brother, chances are his size wise, you can put a lot of pressure with your own hands to stop a lot of that bleeding. I teach some of my young scouts, and some of those folks are about maybe all of 70, 80 pounds. If you really need to, take your knee and stick your knee where the bleeding is at, and just put all the pressure you can with your knee, forcing it in there. Because again, if you're an 11-year-old, some of my 11-year-old scouts and stuff, if they make 100 pounds, I'd be very surprised. Some of them probably in the 70, 80 pounds. Yeah, put a knee in there, put as much pressure as you can. And it's one of the nice things, if the patient's complaining, you're probably doing it right. All right. Thank you, awesome kid. Is there just regular kid out there somewhere?
I have a quick question while we're waiting to see if anybody gets brave enough to ask one. Can they, I mean, I'm sure that there's amount of blood that's too much to lose, but should you worry about the amount of blood while you're trying to get that tourniquet on and stop it before paramedics get there? Like, should that panic you or worry you anymore, the amount that they're losing?
No, go ahead. Losing any is bad. So your object is keep all the red stuff on the inside. Much red stuff I want to, because again, you can't make that judgment call. I give you a number, an absolute number, but in the real life world out there, you're not gonna be able to make that judgment call. You're trying to keep as much of the red as you can.
Gotcha.
Anybody
Jack?
else?
Jack had his hand up a moment ago. Did you still have a question, Jack? No? Okay.
All right, well then, I guess
Grace?
you have number. Oh, there you go. Yes, awesome kid again.
If somebody like lost their whole arm or leg, I assume you would do like a tourniquet, but then would you like I don't know, like just like layer up a bunch of gauze or something? Like, how
Yeah,
would that
take your
work?
t-shirts, shirts, punch as much stuff as you could punch in a hole. And I think he made that one demonstration there where if you lose if I say I lose an arm, I'm doing something driving along, have it out the window, or something falls and pulls it off. Yeah, put as much pressure as you can to where it's going to bleed out. And that's going to be really hard, to be honest, to stop it. But again, take as much biggest gauze, as much stuff you get, and push as hard as you can. And again, if you got to sit on the patient, put your knees into the patient, whatever you got to do to try to put that amount of pressure. Now, the military has some play toys for that, but again, they see that unfortunately too much. But that's the nature of how those boys and girls play. So you thinking about being a trauma nurse or trauma doctor? No. It's a good field. It's a rewarding field. And most of the folks I know basically start off like you guys, have a love for medicine or a love for EMS and want to get into it and involve it. Maybe hopefully in the future we can do a presentation on AEDs or CPR or anything else you guys want to come in the medical field. Just let your friend know, and we will gladly see what we come up with. Yes, awesome.
My brother Jack and I are actually already CPR certified and AED certified. So
Very good, very good. And you tell me you don't want to be a trauma surgeon? Come on now, or at least a veterinarian. You take care of sick animals or hurt animals. Don't want to do that either. Okay, maybe a chef. You can cook tasty animals.
Jack, did you have a question or are you just waving at us? Yeah. Go ahead.
About what you said about Grace being the awesome kid. Well, there's not a regular kid. There's only an awesomer kid. Me.
That doesn't answer the question.
All right, I lost that one somewhere. So there should be an awesomer kid versus an awesome kid. You're right. There's hopefully there's no regular kid out there. There are no such thing as regular kids.
Mm-hmm.
All right, well, Sandy, let's see something else for me. I've enjoyed it. It's been fun doing this thing. And again, you came up with another subject. I'd love to do some of this, so we can eventually do it in person and let them really play with some stuff.
Definitely. I think they would love that. And I would love that. Thank you so much. And thank you for your time tonight. We greatly appreciated it. I think they learned a lot, and I will definitely be in touch to have you back. Thank you so much.
All right. So guys, one last question real quick. Did I gross her out more than you, or did I gross Sandy out more? Who got grossed out more, Sandy or the kids? I'm voting. I think Sandy got grossed out more. Okay, guys. Appreciate you. Thank you very much. And God bless.
Bye,
and see you guys on another minute.
everyone. Good night, everyone. Thank you.